Good morning, everybody. My name is David Shultz. I'm a physician and scientist at the Princess Margaret Cancer Center in Toronto, Ontario. And on behalf of my collaborators, Kim Edelstein and Rhonda Higazi at Princess Margaret, I'm going to be speaking about our funded project today, which is studying the neurocognitive outcomes in patients with advanced metastatic cancer with and without brain metastases. I don't have any disclosures. So brain metastases are the most common malignant brain tumor in people. In other words, it's not the most common primary brain tumor and not the most common primary malignant brain tumor, but among malignant brain tumors, it's the most common. Brain metastases are when you have a cancer somewhere else in your body that spreads to your brain and forms a tumor. Most brain tumors, most brain metastases come from patients with lung cancer because lung cancer is one of the most common solid malignant tumors, and it is prone to spread to the brain. Otherwise, most of the patients who we see with brain metastases have either breast cancer or melanoma, but many other types of cancer also spread to the brain, for example, from the kidney or from the gastrointestinal system. And the incidence of brain metastases is increasing among patients with cancer because patients are living longer with their cancers. There's better treatments for patients who have metastatic cancer. And as a result of that, more patients are living with brain metastases. Unfortunately, most patients with brain metastases only survive, but there are some patients who live much, much longer than that. And again, that's in many ways due to better treatments, including better ways of treating brain metastases, but also better ways of treating the cancer outside of the brain. The three ways that we treat brain metastases are with radiotherapy, and I'm a radiation oncologist, so that's what I specialize in. But we also work closely with surgeons who can resect brain tumors. And increasingly, there are better medicines for treating patients with metastases to the brain. In other words, it used to be that traditional chemotherapies weren't very effective at treating brain disease because they couldn't cross the blood-brain barrier. But as there have been developed molecular inhibitors that are used to treat cancer, like tyrosine kinase inhibitors that are used to treat, for example, EGFR-positive lung cancer, or immunotherapy, such as what's used to treat melanoma, those medicines do have activity in the brain. And so in some instances, those medicines alone are effective treatments for patients with brain metastases. So one of the things that we're interested in is cognition. And cognition has become an increasingly recognized endpoint or important endpoint in treating patients with brain metastases. In fact, it's the primary endpoint for several ongoing clinical trials with brain metastases and was the primary endpoint for the last 3 or 4 big trials in patients with brain metastases. And the reason for that is because what we've learned is that the ways in which we treat brain metastases don't tend to influence patient survival very greatly, but they do impact cognition. And cognition means, your ability to think in various ways. For example, your memory, how your executive function, really all aspects of thinking. And obviously, cognitive function is a very important aspect of quality of life, and it impacts a patient's ability to receive treatment, work, it affects their relationships, and probably most importantly, patient independence. So we want to better understand who among our patients with brain metastases are at greatest risk for decline, and also try to learn about what we can do about that. So cognition is a challenging thing to study in patients with cancer because there's so many things that influence it. Treatments influence what patient cognition. For example, radiotherapy, whole brain radiotherapy can impair cognition, for example. Other aspects of the cancer treatments, such as medicines, particularly narcotics, affect cognition. Just having cancer can affect your cognition. And then there's lots of things outside of patient cancer treatment that affect how their cognition might change in the course of having cancer. So what we wanted to do was to better understand how patients' cognition changes before and after treatment for brain metastases. And this is a subject which hasn't been all that well studied, surprisingly. As I said, cognition was the endpoint of several past trials of brain metastases and some ongoing ones, but most of those trials tend to capture changes to cognition which are in the short term, for example, 3 months to 6 months after treatment. And that's because mostly for practical reasons, but obviously we want to understand also how patients' cognition is affected a year or more after their treatment, because long-term survivors of patients with brain metastases, of which there are thousands in Canada currently, want to continue living their lives and we want to better understand how their cognition has been affected by their treatment and by their cancer. So we set out to study patient cognition, and there's a slide coming up that'll explain it exactly at what time points and how we do that, but basically to study it before we treated them for their brain metastases and afterwards. And we wanted through that to try to better understand exactly what affects how a patient's cognition is changed. So we happened upon a twist to this study, which is that we, in addition to studying patients with cancer who had brain metastases, we also included patients who didn't have brain metastases, so we could directly compare ways in which cognition changes after a cancer diagnosis for a patient who does or doesn't have brain metastases. And in addition to looking at neurocognition through a series of tests that we do, we also look directly at their quality of life and try to understand how changes to cognition affect quality of life. And we do that longitudinally, which means in a time before their treatment and then every 3 months afterwards. And we've compared changes to cognition and quality of life in patients with brain metastasis or without, and identified factors that affect that. So you can see here that currently we've enrolled 152 patients, 103 of whom had brain metastases, 49 who didn't. And to reduce variables that might make an analysis difficult, we've directly compared patients with non-small cell lung cancer with and without brain metastases directly, because their treatment is relatively uniform, and they tend to have a lot of the same external factors that can affect cognition. So far, of patients with brain metastases, 103 of them have completed testing before their treatment. They then received treatment, which in every case included radiation treatment, usually stereotactic radiotherapy, which is focused radiotherapy treating brain metastases. And then at 3 months, we tested 89 of those patients. Unfortunately, 14 of them had died before the 3-month mark. And then at 6 months, we tested an additional 58. So you can see that the number of patients at baseline had almost by 6 months. And some of that is due to patient death, and some of that is due to patients who no longer wish to undergo testing. And sometimes patients decline and can't undergo testing. But for the 58 who had made it to 6 months, many of them actually have continued testing up to 2 years. And so we're really getting a better sense of how their cognition changed. And then among patients who didn't have brain metastases or don't have brain metastases, we have enrolled 49. And about 32 of them had remained on study at the 6-month mark and have remained moving forward as well. And we've been comparing the differences between patients with and without brain metastases. This is the way that we study cognition. You can see that there's a series of neuropsychological tests that we do, and these are tests that are validated to assess cognition in patients, specifically in patients with cancer, with brain cancers. It includes tests of long and short-term memory, executive function, and other aspects of what's considered cognition. In addition, we conduct 3 different ways of assessing patient-reported outcomes, including the FAT-COG tests, an ER2C series, and then a test that specifically assesses depression and anxiety in patients. You can see here that there's greater than we assessed among patients with and without brain metastases, the types of domains that are affected in their cognition. And more than 50% of the patients we've tested thus far were impaired in more than one domain. Interestingly, however, our assessment shows that there actually isn't a significant difference in the cognition among patients with and without brain metastases at baseline. And that may seem surprising, but it's not surprising to those of us who treat these patients. And the reason is because having brain metastases, which typically aren't very large, don't take up a large part of the brain, and which can be very effectively managed in the current era with surgery and radiosurgery and as medicines, as I said, don't have a especially significant impact on cognition. Most of the patients that we meet in our brain metastasis clinic feel relatively well and aren't confused, don't have some of the traits that you might just sort of inherently recognize without testing as exhibiting or as reflecting a cognitive impairment. So, in this rigorous analysis, you can see that something called the cognitive composite score, which is basically using many of those different, many aspects of those tests, shows that the impairment rates were about 50% among patients with and without brain metastases. And what that says, and several of these other ways of assessing the data, including of memory alone, executive function, attention, et cetera. What this data tells us is that it's really the other aspects of cancer that most strongly affect cognition, at least at baseline. So again, this is just the baseline data. That's what we've assessed thus far. But this is actually, I think, in some ways of great reassurance to patients, because one of the really scary things that I think patients experience when they're diagnosed with cancer and when they have brain metastasis is the concern that their cognition is going to be greatly affected by that. And the fact is our data shows that it's probably not. Their cognition certainly is affected, but it's affected by the things which you could naturally understand would affect that, such as the anxiety, their stress of having cancer, some of the medicines that they may have already started for their cancers, and the other things that are going on in their lives at that point that are affecting their ability to think as clearly as they may otherwise. So we also looked at specifically in patients with brain metastases about the factors or the predictors of cognitive performance. So again, at baseline. So basically the higher your intelligence quotient was prior to getting cancer has a great effect on how it will be once you have brain metastases. Men tend to be more impaired after being diagnosed with brain metastases than women are. Not surprisingly, performance status is a predictor of cognition. Having received less chemotherapy is advantageous. And chemotherapy, like radiotherapy, is known to impair cognition. And finally, whether your brain metastases were diagnosed at the time you got cancer or afterwards affects how much those brain metastases affect cognition. Interestingly, the number of brain metastases you have, or the volume of brain metastases, which means if you add up how much volume each of your brain metastases takes and take the sum of that, does not affect cognitive performance. And again, that was perhaps surprising to some people, but again, I think is of some reassurance to patients who really worry that those brain metastases are going to affect the way they think, and it does not seem to be the case. So that's what I wanted to talk about this morning. That's our the initial analysis that we've done over the past year with the data that we'd gotten through this trial. We'd like to thank all the patients who have participated in the trial. We'd like to thank the people that funded this. That includes, of course, the Brain Tumor Foundation of Canada and our other collaborators on this project, whose names you can read on the right. If you have any questions about our study that you'd like to direct to me or to other members of the team, please contact Susan at the Brain Tumor Foundation, and she'll send those questions to me, and I'll happily answer them. Thank you.